Good afternoon and good morning. Today, with the World Obesity Federation, we will be discussing the webinar, which is A Time Is Now, Action on Obesity in the Time of COVID-19. We're delighted to have you here today on Thursday, September 17th, 2020. It's important for us to note that COVID-19 has really affected all of us, and obesity has emerged as a risk factor for hospitalization, intensive care, and mortality amongst patients with COVID-19. These risk signals persist after adjusting for age, sex, and major obesity-related diseases, which include diabetes, chronic cardiac, pulmonary, and kidney disorders. It's also important to note that disparities have emerged in the midst of COVID-19, with persons that are from minority ethnic groups, particularly those that are Black, Latinx, for example, experiencing a disproportionate burden with COVID-19. Today, we'll explore some of these concepts with our amazing panel of speakers that we have today. I would love to take the time to introduce our speakers representing several different groups and countries that will be presenting today. First, we'll have Dr. Olivia Barata Cavalcanti. Dr. Cavalcanti has almost a decade of experience in public health with a special focus on obesity and public-private partnerships to fight non-communicable diseases. She has worked for different international and nonprofit organizations in Europe and in the US, where she was responsible for all aspects of design and implementation of different health programs on diabetes, obesity, and cardiovascular disease for both children and adults, with a focus on low-income settings. She also has a deep knowledge of and experience with the UN system, having worked for UNAIDS in Mozambique for the US Fund for UNICEF, and as a fellow at the Italian mission to the UN. Olivia has experience teaching public health, community health, and research method courses in different universities at both the undergraduate and graduate level. She earned her doctorate of public health degree from SUNY Graduate School of Public Health and Policy, and she also holds a Master's of Public Health and Master's of International Affairs from Columbia University. She was born and raised in the beautiful Rio de Janeiro and has lived in Rome, New York, and Maputo before landing in London. Dr. Saman Bakera is a medical doctor with a master and PhD in nutrition from Tufts University, level 3 member of the National Research System, the National Academy of Medicine, and the World Obesity Federation. Has been a consultant for WHO, UNICEF, FAO in the field of obesity and chronic diseases, just to name a few. He has more than 270 publications in scientific journals and over 18,000 citations. Among some recognitions, he has received the Tufts University Nutrition Impact Award, as well as the distinction of teaching the 11th Michael and Susan Dell Chair in Child Health at the University of Texas in 2017, and the 18th Carl Madison Chair at the University of Minnesota in 2018. Dr. Barquera currently serves as a leader in the line of obesity, diabetes, and cardiovascular risks, and is the director of the Nutrition and Health Research Center at the National Institute of Public Health of Mexico. Richard Sangster is the head of obesity policy team at the Department of Health and Social Care and has been for the last 5 years. During this time, he has led on the development and delivery of the government's obesity policies and strategies. Before this, Richard worked on a number of different portfolios in the Department of Health and the Department of Education. Dr. Rubina Shabin is a medical doctor with a master's degree in public health from Johns Hopkins Bloomberg School of Public Health, and also possesses an MD in clinical microbiology. She has a technical administrative background of more than 22 years in the public health sector and food safety, and she has a number of research publications and books to her credit. She is a fellow of the International Ford Fellowship Program and also a member of the Indian Public Health Association. Currently working as a technical director with Food Safety and Standards Authority in India for the last 5 years. One of my colleagues, very close, but also very early in the morning for him, just like myself, Dr. Arya Sharma, is a professor of medicine, past chair in obesity research and management at the University of Alberta in Edmonton, Canada. He's also the clinical co-chair of the Alberta Health Services Obesity Program. He's the founder and scientific director of Obesity Canada, which was formerly called the Canadian Obesity Network, and a network of over 10,000 obesity researchers, health professionals, and other stakeholders. He's also past president of the Canadian Association of Bariatric Physicians and Surgeons. He has authored or co-authored more than 450 scientific articles and has lectured widely on the etiology and management of obesity and obesity-related disorders. Dr. Sharma is regularly featured as a medical expert in national and international TV and print media and maintains a widely read obesity blog, www.drsharma.ca. And I would be remiss if I did not introduce myself. My name is Dr. Fatima Cody Stanford. I'm an obesity medicine physician and scientist here at Massachusetts General Hospital and at Harvard Medical School. I'm one of the first fellowship-trained obesity medicine physicians in the world. I hold several degrees, working on my fifth now, my bachelor's in science and master's of public health from Emory University, my master's of public administration from the Harvard Kennedy School of Government, my MD from the Medical College of Georgia, and currently working on my MBA. Without further ado, I'd love to introduce our speakers, but I also wanted to go over a few housekeeping rules. First of all, this webinar will be recorded. Please use the Q&A function to post comments and questions. We will try to get to as many as we can during the course of this webinar. And the recording, slides, feedback form, and certificate of attendance will be circulated post the webinar. So you can see our robust agenda for today. We've already gone through our introductions. And without further ado, I would like to bring in Dr. Bharata Kalvankanti. We'd love to hear your slides now. Thank you.
Hi, Fatima. Thank you so much for the introduction. So, as usual for our webinar series here at World Obesity Federation, we like to start with brief recap and introduction of the COVID-19 situation and what have we discovered between the association between COVID and obesity. So first of all, we wanted to show the map of the number of cases and fatalities in the world right now. As you all probably know already, we're reaching almost 30 million global cases, and we're very close to the 1 million deaths around the world. And because this is a global event, I'm sure that some of you are in places now that are experiencing the second wave. Some of you might still be on the first wave. Some of you might be lucky enough to be in a country that is managing an effective response to the pandemic. But it is important to remember, and that's why I do like to show the Johns Hopkins map. If you see the graph to the bottom right, that the number of cases is actually still a little bit upwards, still increasing. So if you go to the next slide, we in the past few months, our lives have been completely changed, and all the information that we've been getting from the news is about COVID. And for sure, we've known for some time now that obesity is undoubtedly a risk factor for COVID-19 complications and mortality. And I wanted to just kind of highlight and bring your attention to two recent studies that explore more in depth the association between obesity and COVID-19. One that specifically studies the association of the impact and association of COVID-19 in young people with obesity. And the other one, which is a systematic review by Popkin that really goes into analyzing all the studies that have been published so far, trying to understand the link between those two diseases. So if we go to the next slide, if we focus on, again, young people with obesity and COVID, we know so far until now, pretty much all we've heard in the news is that the elderly, so people at older ages, are the ones that are more vulnerable to COVID-19, not only to catching the virus, but also to having more complications and mortality. And we do know that the prevalence and the mortality rate of COVID among young people is much lower than those among the elderly. But now that we have a large number of patients with COVID-19, and we have, especially now during this second wave in many countries, we're seeing many young people with COVID-19, we are starting to see that the number of critically ill cases is rising among this population as well. So this study, which is a retrospective cohort study, it was conducted in Wuhan in China. It included 65 patients between 12 and 40 years old. And what it found is that, first of all, the patients with severe complications of COVID had higher BMI. You can see an average of, 29, so almost 30, compared to the group of moderate cases. And that obesity is an important predictor of severe COVID-19 among those young patients. And we definitely need further analyses to understand better this association, but we do know, and what Dan et al. Found in this study is that obesity mainly affects the severity of coronavirus through the deposition of ectopic fat in different organs, which in turn damages the organ function. And according to this study, the organs that are more likely to be affected were the liver and kidneys. And those are very important discoveries as we are now starting to look at different therapies and how to treat obesity. Second slide. And then, you probably have heard about this study. This was the Popkin et al. Meta-analysis, and it really looked deep into 75 different studies. So they first did a systematic research of Chinese and English literature on COVID-19, and included 75 studies, and conducted a series of meta-analysis on the relationship specific between COVID-19 and obesity. And first of all, they saw that, as we already knew, having obesity does increase the odds of COVID-19 patients being hospitalized. And the New York example is a good one. So as in New York City, the average prevalence of individuals with obesity is 22%. But at the same time, in the same city, almost 42% of the hospitalized COVID patients were actually individuals with obesity. So you can see there's a much bigger percentage. Two different studies that were included in this meta-analysis also show that the odds of having coronavirus increased by over 30% among individuals with obesity. And it concluded that, unfortunately, all the different mechanisms that are responsible for this increased severity in individuals with obesity is unknown. However, and if you want to click, Claudia, there is a graph from the study that I wanted to show. So we don't know exactly the pathway that goes from an individual with obesity having COVID-19 and the hospitalization, but we do know that there are a series of changes, mechanistic changes, physical dysfunctions and comorbidities that, probably interacting with each other, lead to that higher severity and complications. So we're talking about metabolic dysfunction, immune impairments. There have been some studies looking at the inflammation. So some people believe that it's because of the inflammation that individuals with obesity do have more complications. So this is something that it will be studied more and more, but we are starting to get a glimpse of those different mechanisms that affect individuals with obesity, and that is extremely important. Considering the exponential rise in the prevalence of obesity in the world, understanding how those people with obesity have, and why do they have an increased risk of severe complication, is critical to make sure that we have the appropriate intervention, treatment, and prophylactic therapies against the virus among patients with obesity. Thank you.
Thank you so much, Dr. Kavankati. We appreciate your overview, your analysis, and also just really taking a look at what we're seeing across the world as it relates to obesity and COVID-19. What I'd like to do now is go into the individual speakers that we have. Each of them will have about 5 minutes or so to present their perspective. What we will do first is go to Simon Bakera. Dr. Simon Bakera, can you speak first, please?
Thank you very much, Dr. Stanford. It's a pleasure to be with you and to share a perspective on the problem in Latin America, and particularly in Mexico, where I live. And I would like to say to start that, as Dr. Barata mentioned, Mexico is sharing this increased risk of COVID-19 severity with obesity. We just published an a study that actually is included in the review by Dr. Barry Popkin that was just presented, in which we found that obesity, diabetes, and hypertension significantly are associated to severe COVID-19 on admission. And also we found that the association of obesity is stronger for younger people, younger adults, younger than 50 years of age. And the main conclusion that we had from this study is the relevance of improving NCD prevention and control, and now includes reducing adverse outcomes to viral pandemics. So it's not only important because the high burden of disease, but now also to reduce adverse outcome of viral pandemics, particularly COVID-19. And for Latin America, we have a very specific challenge. We have more than 48 cities that have above 1 million inhabitants, and we have two of the most populated countries in the world, Brazil and Mexico. And we are experiencing a very important transition, a nutrition transition, in which in Brazil, Chile, and Mexico, all have a consumption of ultra-processed foods that is above 20%. Argentina, Brazil, Chile, Colombia, Peru, and Mexico are above the highest consumers of sugar-sweetened beverages in the world. And the non-communicable chronic disease are the main cause of death in Brazil, 74%, Chile, 85%, Colombia, 75%, Mexico, 80%. We are one of the most unequal regions in the world, with a very poor infrastructure to respond to the COVID-19, with no increase in health investment since 2000 on average for the region, with an investment of only 6.5% of the gross national product. And the other important thing is that COVID-19 has some effects on lifestyles that are not helping a lot in the region. It is producing decrease in physical activity and a rising consumption of ultra-processed foods, basically through many mechanisms, but some of the most important are because of the confinement strategy, also higher exposure to junk food marketing from the increased screen time, and also rising food insecurity. For example, in Mexico, there will be more than 10 million new food insecure people in after COVID. So just in these few weeks. So this is a very important moment and a very complicated one. So some of the key priorities for Latin America definitely have to do with the policies to improve the food environment. It is not likely that we will have resources to invest a lot in treatment of obesity, but we definitely have shown that we are able to promote some policies that are effective to prevent obesity. And this is the window of opportunity to do it, because we have support. There is many people interested on identifying some additional ways to help to decrease the burden of COVID-19. So soda, junk food, alcohol, and even tobacco taxation is a very useful strategy to increase revenue. And also it's a very useful strategy because we know that it's effective to disincentive the consumption of these products that are unhealthy. Also, the front of pack food warning labels that Chile started in 2016 have now been implemented in Mexico and are a very powerful strategy to disincentive consumption of unhealthy products such as sugary beverages and junk food. And we are one of the highest countries, the country with the highest number, the region with the highest number of countries that have implemented soda taxes, but we still can refine these taxes. We have a strong regional network. We share a common language and a lot of relations between academia and policymakers. So those are advantages. And just to conclude, we have some challenges in which this international collaboration is very important. And one is help from organizations such as World Obesity and also non-governmental organizations such as PAHO, WHO, UNICEF, to expose and neutralize the constant industry interference in all the policies to prevent obesity. This is something that has happened in Mexico for the last 20 years, and that has made very difficult to implement these policies. Now we are experiencing and documenting a lot of COVID washing practices in which these companies deploy a very aggressive strategy of support and messages of union and of care, while at the same time promoting products that we know that are harmful for the health of the people. And finally, we think that in the healthcare and attention, we need to focus on low cost effective primary healthcare practices, because it is not likely that with our amount of resources, we are going to be able to implement multidisciplinary, very complex treatments. So we need to start with these few steps. And I think this is more or less the perspective of what we are experiencing in Latin America. Thank you very much.
Thank you so much, Dr. Baquera. If we can now go over to Richard Sangster, but before you start, Richard, just a note to all of the persons that are viewing, the panelists are not sharing slides, so that is not, that is by design. We will have them all appear when we go into the Q&A after each of them have had a chance to speak. Thank you so much. Richard, if you can speak, thank you.
Thanks, Fatima, and good morning, afternoon, and good evening to everyone. And I'm Richard Sangster. As I introduced, I'm kind of head of obesity policy at the UK government in London. Perhaps I slightly need to up my biography game because it was quite short, but I won't bore you any further. I just wanted to say a few quick introductory remarks about what we're doing in the UK on obesity, but also the impact COVID-19 has had on the politicians here, but also on policymakers and our response to COVID. And obviously kind of happy to answer further questions in our Q&A. I'd start by saying that, you know, in the UK, we take obesity incredibly seriously. Anyway, you know, it's a huge issue in the UK. We have about 1 in 3 children leaving primary school overweight or living with obesity, and about 25% of our adult population is also living with obesity. So it's a huge challenge, and it's very much kind of recognised. But our kind of policy response so far has tended to focus on children and tended to focus on those kind of preventative actions that we could take to reduce those prevalence levels of obesity. So the challenge has always been there, but I think what COVID has done, and I won't repeat the excellent introduction around those kind of associations, but what COVID's done is made very clear that there is a much more kind of immediate impact around obesity, and you know, there is you know, a sense you know, on an individual level, on a population level, that you know, some of the effects of obesity are quite long term. You know, it's not an immediate health impact, but I think what COVID has definitely done is brought that to the fore, and it's definitely made people think much more immediately about what can be done. And I think as well, you know, it would be fair to say that our own Prime Minister, Boris Johnson, you know, contracted COVID-19 pretty bad himself, and you know, felt personally that you know, his weight was you know, a significant factor in you know, his COVID-19 problems. So I think that has obviously kind of personally affected him, and you know, the way in which the government responds to that. So we people may know, I can send a link around, we published just over a month ago a new strategy for tackling both children and adult obesity, which we kind of recommitted to a number of things that we we were working on around the sort of prevention measures for obesity, so around kind of labelling. Colleagues mentioned front of pack, including that, but also kind of calorie labelling. Looking at introducing laws around kind of marketing promotions, but also kind of advertising of what we call high fat salt sugar products, both online and on broadcast TV. So we're moving forward with that package with I suppose kind of renewed vigour. But I think the other thing that COVID has done has made the government think that we need to invest much more in the services to help people lose weight, and we have created a new kind of health campaign to highlight the importance of healthy weight and healthy diet in relation to COVID, particularly, and helping people with a range of new downloadable apps that people can take advantage of. But we're currently thinking at the moment about what the size of investment we could put in to kind of those treatment services, whether they're kind of lifestyle treatments or whether they're kind of more specialist services. And so we hope to be able to say much more about that towards the end of the year, as hopefully we get a good kind of financial settlement to put those kind of services in place. And also, thinking, it's very difficult, obviously, to predict how COVID will go. So thinking a lot more about how we can make those weight management services digital, and providing that kind of flexibility for people. The final thing I just mention in terms of kind of COVID response is that we will be thinking about what are the kind of research needs, what are the kind of understanding of how COVID has changed people's eating habits, people's consumption habits, so we can kind of better understand how we can respond to kind of obesity going forwards. Thank you.
Thank you so much, Richard. So we will go into Dr. Rubina Shaheen, if you can offer your brief.
Thank you so much for inviting me on this show, this webinar. And since I will be talking about as a regulator, mostly on our what actions we have initiated as far as the problem of cardiovascular diseases in India is concerned. Since we know that India is going through a demographic transition, that we have malnutrition, that we have people with undernutrition, as well as people having non-communicable diseases. So as we know, globally, the industrial trans fat has taken a lead of more than 5 million deaths from cardiovascular disease, and India is figuring at around 60,000 deaths are contributing towards this global scenario of cardiovascular deaths. So what India has done is that we have been progressing towards its objective that we actually reduce or eliminate the trans fat by 2022, and we are going a year ahead of the global target by WHO. So FSSAI has committed, as a Food Safety Authority of India, as a regulator, have committed to reduce the industrially produced trans fat to less than 2% by year 2022, and that will be done in phased manner. And we have geared up to get freedom from this trans fat with the motto of India at 75, that is freedom from trans fat. FSSAI has also, we have finalized the trans fat regulations in all fats and oils, and we have also now extended these regulations to food products, other food products. And right now we have limited the presence of trans fat to 5%, less than 5%, but then we'll be now going up to 2%. And in addition to these integrated disease, this integrated child, and development scheme and midday schemes, They have also been advised not to procure or use trans fat containing fats and oils like vanaspatis and in preparation of food, and also desist from procuring such products which are being prepared by using margarines and bakery shortenings. And in July 2018, FSME already launched an Eat Right India movement, which is a multi-sectoral effort to having a primary focus on reducing our daily intake of salt, sugar, and fats. And that's again phasing out trans fat from our diet and promoting healthy food habits in our consumers. The movement has actually been targeted both on the supply side as well as the demand side. And from supply side, it is actually focusing on our industry associations, and so they have already taken a pledge so that they eliminate trans fat from their products. And there are many associations like Indian Vanaspati Producer Associations and Solvent Extractor Associations and Vanaspati Manufacturers Associations who have voluntarily taken a pledge to bring down trans fat from the existing 5% to 2%. And whereas on the demand side, we are creating an awareness among consumers so as they can reduce the acceptability of this industrial trans fat in food. We have launched a media campaign called Heart Attack Rewind, which is a campaign that has been well received by masses and that has really achieved a success in generating awareness among masses. As we know, this during COVID, there has been lockdown, and people have already switched over to homemade foods. So this has also helped in that way, that people are now innovating new recipes and healthy recipes even at home. So that is also what we have been trying to do. We have been putting in on our websites the new recipes which are more healthier to take, which can reduce the level of these fats and trans fats in the food. So in addition, we have a labeling regulation in place which makes it mandatory to mention the trans fat content and the salt and fat content also, as well as saturated fat content on the label of oils and fats that are being used in production of the food products. So this is one more thing. And in addition, we are also working on front of packaging labeling, where it will be marked whether the product is high in sugar, salt, and fats. And recently, we have FSSAI has also released a trans fat free logo in July, which is actually a trans fat free logo may be used by the food establishments which are using trans fat free fats and oils and do not have industrial trans fat of more than 0.2 grams. That's less than 1 gram per 100 gram of food. And so they can display it that it's a trans fat free food in their outlets or on their food products. And this logo, use of this logo is again voluntary. In addition, FSSAI is also actually we have upgraded our lab system so that the testing can be possible. And these are some of the good initiatives which we have been taking since last year, so that we can come over the problem of obesity as well as the non-communicable diseases. Thank you.
Thank you, Dr. Shaheen. I appreciate that. As we are going into Dr. Sharma, who's our last speaker, just a note, please put any comments or questions that you have in the Q&A. Also, please be mindful of the language that you're using to talk about our patients that have obesity. If we can eliminate the word obese, that would be great. Obese is a label, obesity is a disease. I've heard quite a bit of things that have focused on nutrition, which is great, but we have to understand the biologic basis. And when we talk about obese, we're promoting weight stigma and bias, which is pervasive throughout the world. So if we can think about that, use people first languages, persons with obesity, patients with obesity, that would be indeed appreciated. And without further ado, I'd like to introduce Dr. Sharma as he gives the final comments from our panelists before we go into our Q&A. Thank you.
Well, thanks, Fatima, and thanks to all the previous speakers for setting the stage so wonderfully. You know, Fatima, as you mentioned,
we can't see your video. Just a note.
Okay, well, I can't start my video, so somebody's got to start it.
Okay.
Here we go. Well, thank you, Fatima, again for reminding everybody that we talk about obesity today not as a risk factor, but we look at obesity as a chronic disease, as something which once you get it, you're pretty much stuck with for life. And that is, I think, a really important perspective that we have to take. As we've heard from many of the speakers here, COVID-19 has really put a magnifying glass on this epidemic. We've been talking about obesity in many of the countries, including Canada, for a long time, but we haven't really gotten our act together much on the prevention side. We continue to see increases in obesity pretty much across most countries, including Canada. And we haven't really done much in terms of providing care or providing access to care to people who've been living with obesity, for a long time. Just to update you on the COVID numbers from Canada, we've had a total of 140,000 people who've had COVID infections. We currently have about 8,000 active cases, which means it's more or less under control. All the numbers in certain parts of Canada are still gradually rising. It's not really a second wave, but the numbers are still trending upwards. And this may still be part of the first wave. And we've had a total of about 9,000 deaths. So overall, COVID is pretty well controlled in Canada. But nevertheless, it has certainly put a magnifying glass on all of the issues that we've just been talking about. As everywhere else, obesity has certainly emerged as one of the key risk factors, and people who have obesity are not only more likely to need hospital services, but are, once they contract the disease and end up on ICU or even in hospital, they have significantly higher risks for overall mortality and complications. Now, having said that, I'm not going to speak about all of the, things that are being done across Canada in terms of prevention, food labeling, etc., because that's really not my area of expertise. I want to look at this much more from a clinical perspective. As I mentioned, in Canada, we try to look at obesity itself as a chronic disease. It really doesn't matter why you gain the weight. The problem is once you gain the weight, your body actually has very powerful biological mechanisms that are going to actually prevent you from permanently losing that weight. So although you might make the effort of trying to lose the weight, and people are successful at that, the problem is that your biology pretty much dictates that your body weight sooner or later is going to go back to where you started, and that's going to be pretty much a long-term fight. Which means that we have to think of obesity in terms of a chronic disease, short-term strategies like going on a diet or increasing physical activity or making other short-term behavior changes, although they might reduce your body weight in the short term, have actually not been proven to have any kind of long-term benefit or any long-term outcomes for most people. And once you understand the science of obesity and the way that bodies actually regulate their body weight, this should not be a surprise to anyone. So while we're waiting for the environment to change, and hopefully, we will be moving towards a more or less obesogenic environment, although that is very, very difficult to achieve, especially, as was mentioned previously in COVID times where people are locked down, there's high stress levels, we have food insecurity, all of the factors that were driving obesity before, if anything, are now, amplified. And that certainly leads a large proportion of the population at risk. Now, one of the things that has happened during the COVID times is that in Canada, Obesity Canada has launched a new set of guidelines for obesity management that have been long awaited and that have taken quite a considerable work, but looks at obesity not only as a chronic disease, but also addresses issues around weight bias, stigma, discrimination of patients with people living with obesity within the healthcare system in terms of access to care, and really looks at the evidence that we have in terms of what is the care that people living with obesity actually need and deserve, and what are the best evidence. And what is quite clear is that although lifestyle management of obesity is important and should be the basis of any treatment for any chronic disease, it turns out that lifestyle management for obesity, if that's all you have, is not really that much more successful than lifestyle management of, say, diabetes, or lifestyle management of hypertension, or lifestyle management of heart disease. We can agree that for all of these conditions, lifestyle management, of course, is important. But if you take a patient with diabetes, lifestyle management, although important, is probably not going to be enough to control that person's diabetes. And we are learning that in obesity, we have a very similar situation, that although lifestyle management of obesity is an important aspect of obesity management, for most people living with obesity, that is probably not going to be enough. Which means that, like for other chronic diseases, we do have to consider other medical treatments, which might include medication. They could include, mental health strategies, and in some cases might even include, bariatric surgery as the most effective treatment for people with severe obesity. Now, this of course puts a huge challenge not only on the healthcare systems themselves to start providing those services, and obviously now that we have COVID-19, the healthcare systems, have perhaps other priorities, and this is something we should have been, doing before all of this started. But I think what we also have to consider is that it is not just a question of finding the resources to provide that kind of access of care. What we've also seen across Canada is that there has to be a mentality shift both amongst people living with obesity who start seeing their own condition as being something that is very similar to diabetes or any other chronic disease, and reach out to their health professionals and their healthcare systems for support. We know that because of internalized weight bias, where patients are basically blaming themselves and think it's their own problem to solve, because those are the messages that they're receiving from public health, are actually very reluctant to reach out to health professionals for evidence-based care. We have got this huge industry of weight loss, strategies, and it's a huge unregulated industry, and we know that people trying to lose weight actually turn to that industry rather than turning to licensed health professionals for medical help. On the other hand, we also know that most licensed health professionals do not have a solid foundation in terms of obesity management. They have virtually no training in obesity management. Many of them, share the same biases and the same stigma, the same discrimination against people living with obesity as the general population. And so even if you do have patients reaching out to their doctors or their health professionals for help, very often we find that they're not receiving the kind of help that they should be receiving, simply because the doctors and the healthcare system itself, the people working in the healthcare system, the policymakers, the people who make decisions, simply do not have a good understanding of obesity as a disease. So a lot of this is now addressed in the new Obesity Canada guidelines for obesity management, and we hope that these will have an impact. Now, having said all of that, just on a last note, it is not just about providing medical treatments for obesity. We also have to consider that there's already a large proportion of people living in Canada who actually have quite severe obesity, and that these patients, in a crisis like COVID-19, face particular challenges when they get admitted to hospitals. And this starts from the size of having appropriate bariatric furniture, to having appropriate blood pressure cuff sizes, to having examination tables. And then when you take this into an intensive care setting, where we're talking about people who have quite severe obesity, there are many, many challenges in looking after these patients. This is not just related to COVID-19, but it certainly highlights the problem that we have within the medical system to provide proper care to individuals living with obesity. And so this is something that I think, which I'm hoping for, is that once we have the COVID-19 problem under control going forward, we will very seriously be looking at what are the services that we need to be providing to people living with obesity, and how can we optimize care for people presenting with obesity who present in the healthcare system with all kinds of medical problems, not just COVID-19. COVID-19 just happens to be the sort of the flavor of the day, but we have a lot of people with severe obesity within the healthcare system seeking help for all kinds of reasons, and we have to think carefully about how we accommodate this important part of the segment of the population within the healthcare system. So I'm going to stop there. I think COVID-19, as I said earlier, has really put a magnifying glass on the problem of obesity, not just in Canada, but I believe around the world. And we need to take this chronic disease severely. We need to step up prevention, but we also need to think about all of the millions and millions of people who are already living with this disease, and have to start thinking about what are the evidence-based treatments that we can provide to all of these individuals.
Thank you so much, Dr. Sharma. If all of the panelists can come on video, we do have quite a few questions. I won't be able to get through them in the time allotted, but there were a few that I wanted to pose directly also that were related to things that were mentioned. For example, Dr. Sharma, I want to thank you so much for your presentation and thinking about the prevalence of obesity throughout the world, and the need for treatment for those patients for this chronic relapsing, remitting disease, for example. My question for you as Canada, US, where I'm based, we're high-income countries. How do you suggest that countries that don't have quite the economic infrastructure that we have go about treating obesity? That's question one. And part of that also is with regards to training, which we know is abysmal, not only here in the US, but also around the world with regards to physicians and other healthcare providers for treating the disease of obesity. How do we tackle that? So that's kind of a multi-part question, but I think related to the things that you've mentioned.
Yeah, well, thank you, Fatima. So when it comes to treating obesity, we know that the treatments are expensive. Even if you talk about lifestyle treatment, you're still talking about spending time with a dietitian, spending time maybe with a psychologist, maybe with an exercise person. All of that costs money, and is clearly not going to be accessible to the vast majority of people. So we have to take a step back and think about obesity as not just as a chronic disease, but actually as a chronic progressive disease. See, if you could just do something to stop everybody at whatever body mass index level they are right now. Going forward, that would already be a big step forward. You can call that secondary prevention, or you might even want to call it tertiary prevention. But we are dealing with a progressive disease, and in any progressive disease, your first step is not reversing the disease, but stopping the progression of the disease. And even slowing the progression of the disease, I think, would already put us forward. Now, the nice thing, or the good thing about stopping the progression is that when you simply try to get somebody not to gain any more weight, you don't have the body resisting, because you're not activating all of those biological mechanisms that will come into play once you lose weight. And so that is a very realistic goal. And I think that if you actually had the resources or if you actually addressed the key issues in people's lives that are contributing to weight gain, in most cases, you can actually get weight gain under control, which means you can stop or decrease the rate of weight gain. So for example, if you have somebody who's gaining a lot of weight because of stress, well, if that person actually addresses some of the issues causing the stress, learns better stress management techniques, you can actually slow progression of weight gain in that person. If somebody is on a medication that's causing them to gain weight, well, maybe you can change that medication to a medication that's less obesogenic, and again, you can stop progression. So I think the first step in this, rather than thinking about how do we get weight down, is how do we stop weight from going up anymore. Now, population measures, of course, are important, but they are not addressing the specific drivers of obesity and the specific needs of people who already have obesity. And so I think that is the first step. Now, what that requires is not a lot of money, but what it does require is a better understanding of the key drivers of obesity at an individual level, and an attitude shift where we stop blaming and shaming the person and getting patients to reach out to the commercial weight loss industry, when really what they should be doing is sitting in their doctor's office and getting sensible advice based on the best evidence. That does not cost a lot of money. That's where we need to start.
Thank you so much, Dr. Sharma. What I want to pose to, so several of the questions, so I'll try to kind of push them together just due to our time limitations, are surrounding nutrition and nutrition policies and whether or not they actually have any efficacy with regards to reducing obesity rates. If we look at the literature, I have some thoughts about that, but I want to pose this to the panelists with regards to things such as calorie labeling, taxation of sugar-sweetened beverages, and giving, I guess, incentives for consumption of healthy beverages. What do you believe the data to be, and do you believe that this is a great public health strategy with tackling obesity, this chronic progressive disease, as Dr. Sharma has mentioned? And so I guess whoever would like to chime in, I'm opening this up to the panelists. I think Dr. Shaheen also is unable to join us for the panel, but for the other panelists, please. Yes, Simon, if you want to talk.
Yes. I think there is a lot of opportunities in obesity prevention strategies. We have a lot of idea of an experience of how these policies can decrease consumption of unhealthy foods, and we understand very well how this consumption of unhealthy foods is related to the development of obesity. Also, there are some models that project, for example, how many cases would you prevent of obesity in the future with just small decreases on average at the population level in consumption of calories. So for example, in Mexico, we estimate that only reducing 37 calories per capita for 5 years with the front of pack labeling, we could reduce more than 1 million cases of obesity and save more than 39,000 million pesos of health expenditure. And we have seen different policies such as taxation of junk food and sugar-sweetened beverages and other policies reduce consumption. So I think this is something very important, particularly for low and middle income countries that do not have a lot of resources to improve healthcare and do not have resources for education and individual activities. And it's obviously complementary of all the other efforts that need to be done at the individual level.
Dr. Becerra, I want to challenge you. So what we do know is a calorie is not a calorie. So it's the quality of the calorie that matters, right? Processed versus unprocessed foods. That's been demonstrated in studies such as the one by Kevin Hall coming out of the NIH, where it wasn't just the calorie itself, but the quality of calories. So if we're looking at lean protein, whole grains, fruits and vegetables as the predominant source versus processed. But what I'm still questioning, and the question I posed, is whether or not we've actually seen evidence that that translates to a reduction in obesity rates anywhere in the world. And so does the taxation, does the calorie labeling, have we seen anywhere in the literature, anywhere around the world, that that actually translates to a reduction in obesity rates? And so that's my question.
Well, I think we need we need time to see these effects, because obesity is a complex disease that needs multiple interventions, but also there is a perception of the effects that is biased by the inability to observe the contrafactual trend. So when you are expecting a reduction, what you need to do is to model what was the trend in the disease or in the outcome, and then compare against that contrafactual. So that is not easy to express and to observe. So for many people, these policies do not have an effect, and really what needs to be done is to express it as a trend and a change in the trends. So I think that is a problem that we have, and we are exploring how to explain better in Mexico to show the usefulness of these kind of policies.
All right, thank you, Dr. Becerra. I'll move on. So I just tried to capture a lot of the nutritional questions within that particular question. Thanks, Becerra, for answering them. There are quite a few questions that have come through with regards to children. What we have heard was that this disease disproportionately impacts older populations. What we're seeing in the US is as children are returning to school, we're seeing a rise and actually seeing deaths with regards to COVID-19, and particularly children who have obesity. What are some strategies that we can think of in terms of working with the pediatric population to reduce their risk, in addition to maybe social distancing, mask wearing, et cetera? And how do we begin to really address this epidemic of obesity within the pediatric population to prevent consequences related to issues like COVID and other diseases? So whoever would like to answer.
Well, maybe I can jump in there. I'm not a pediatrician, and I don't see I don't see kids in my practice. But what I've learned from my pediatric colleagues is that, like many other problems, but particularly obesity, it tends to run in families. So this idea that there's something that you can just do for the kid in isolation that's going to change their lives and solve obesity. At the same time, you've got the parents, you've got the grandparents, you've got the family, the uncles, the aunts, also living with obesity. There really isn't very much you can do for the kid, because the kid is going to be exposed to that entire environment. And so even if you do have a meal program where the kid is getting certain foods, healthy foods, hopefully, when they're in school, well, they come back home into that environment where their parents are dealing with the same issues. And then you add on top of that COVID, where you're not participating in the usual sports, you don't have this regular curricular activity, opposed extracurricular activities where you can go after sports. You've got the parents confined, you've got the financial problems, you've got the whole economic stressors, and simply the stresses of being confined inside, if that's what's happening. Now that obviously affects the health of the kids, but it affects the health of the whole family. So looking at childhood obesity in isolation from what's actually going on with the entire family and the entire family unit, and perhaps with the entire community, is not going to be very successful. You can look at individual kids, but you have to change the environment for the entire family unit. And you can't just think of this as something that you're going to do for the kid, when really the parents, and in contrast, what we've actually seen in our program is that as we provide effective obesity treatments to parents, their kids get healthier, Because if you actually start treating obesity in the parents and they change their lifestyles and they have, they make changes, that indirectly actually benefits the kid probably even more than if you spend that same resource on the kid itself. So that's my view on this, not speaking as someone who's an expert on childhood obesity.
Thank you so much, Dr. Sharma. So I am a pediatrician and an internist and an obesity medicine physician. I feel I could answer the question, but I wanted to pose it out. But I do think you bring up an important risk, and I want to, address this. Maybe Richard, you can also talk about this. What we do know is that weight is by far more heritable than height. And I like to bring that up again. So weight is more heritable than height. That means that if a parent has obesity, the likelihood that their child will indeed have the disease of obesity is on the order of 50 to 85% likelihood. That is even if we maximize things such as nutrition, environment, for example. So how do we begin from a public health perspective to really tackle this intergenerational transmission of the disease of obesity? What are some strategies as we think about issues such as fetal programming and how that plays a role in mom and her offspring for the likelihood of having obesity? So I'd love to pose that, maybe Richard, you'd like to chime in, or whomever on the panel. That would be great.
It's a huge question. And I think, I
like to keep it challenging, Richard.
No, it's you can speak for days on it, and I think, if you were to boil it down, I think it would be strategies to tackle childhood obesity or adult obesity or family obesity. I agree, it's all the same contribution. There's got to be kind of holistic. It's got to hit as much as possible. I think I've always thought you've got to throw the kitchen sink at it as much as possible, and whether that's in terms of treatment, in terms of kind of what you do in early years, in pregnancy, in schools, in local areas, in the treatment services you offer, the kind of obesogenic environment, making sure you can do as much as you can about marketing and kind of promotion and giving people the right information to make kind of healthier decisions. There's no one kind of policy or program or intervention that's gonna help. It's all those things coming together. I think what that means, and it goes back to the last question, is, well, how do you demonstrate that's worked? And I think we are you challenge about where has it worked, and I think we are globally at the kind of foothills of our understanding of what works. We have some good data, we have some good evaluation, but so much more is needed. And it's only in some cases by kind of taking these steps, taking these measures, putting in the right evaluation, that we're going to kind of move on from it. And one of the things we're very clear about doing in our strategies in the UK is making sure that we've got the evaluations in place, and we've got the the benchmarks and the data to be able to kind of really challenge ourselves that these things are working or not. And so that's kind of really important. So in short, we need to do everything as much as possible, but you've got to take people along with you on that journey. And that's the challenge for government is people need to eat. People enjoy eating. The industry and the businesses around food are kind of huge and employ a lot of people. So it's a journey, and you've got to take people on that. And I think it can be a slow journey, but I think COVID has, in a way, for many countries, kind of shone that spotlight and may well kind of speed that journey up for many people.
Thank you so much, Richard. I know that we're nearing the end of the hour, and some of our panelists may have to leave. So I want to, first of all, thank each and every one of you for attending. We've had a great representation throughout the world from many countries. I think what we have discovered from this particular presentation is that we have a lot of questions, but not necessarily a lot of answers. But we have to think about the complexity of this disease of obesity and making sure that our strategies from a health policy perspective align with that complexity to ensure that we actually have outcomes that are produced and are felt by patients, whether they're pediatric or adult, whether they're from minority groups or not, on the ground. And we didn't really get a chance to delve into social inequalities and its role, but we do know that that plays a large role both in the US and around the world. I do want to show, give a few information pieces here that you'll see on the slide. The World Obesity Federation has launched an online dossier with a compilation of documents on COVID-19 and obesity. World Obesity Live will continue on Friday, October the 8th. It will focus on COVID-19 and obesity. So I want you to watch out for additional registration information. You can see the COVID-19 resources along with the website that you can go from the World Obesity Federation. And also there are, on this particular slide, information provided for Scope e-learning along with the Scope Twitter handle, as you can see here. Please be working on this particular issue. I don't think COVID-19 is going anywhere anytime soon. It will be part of what comes part of our lexicon as we go forward. But I thank everyone for really being actively engaged and working from all different strategies, whether they be on the clinical treatment side, whether they be on public health side, public administration, but recognizing that to treat this multifactorial disease, we need multi-sector approaches. I want to thank you again for your time. If there's an additional slide, I want you to complete the feedback form. That is going to be important. And if you have queries, please contact World Obesity at inquiries@worldobesity.org. Again, my name is Dr. Fatima Cody Stanford. I want to thank you so much for your time on either this morning or afternoon. We want you to have a wonderful day. Goodbye.